So welcome everyone to our Link and Learn session today hosted by Malawi. I just want to say that it would be good to know who's with us. So kindly just on the chat, you can introduce yourself and also your country and maybe your position. But for today's session, we will be talking about demand generation for condoms as well as and how that links up to distribution. And Malawi is going to be sharing a little bit more about their experiences. And if you have any questions, also just kindly put them down in the chat and we shall be addressing them at the end. So at this particular point, I want to welcome Betha to take it away. Welcome so much, Betha.
So thank you very much. I'll take you through the background of where we are coming from as Malawi and what propelled us to start integrating condom distribution and condom promotion. Next slide, please. So just giving a background situation of Malawi, we are one of the highest debated countries in the world where HIV is concerned, and our SRHR situation is not one to be proud of. So our background dates back to the year 2022. We started the integration in the year 2023. When we were starting with the integration, we had just registered an estimated 15,500 new HIV infections, and we were standing at a prevalence rate of 7.7% in the adult population. Our disaggregation of data showed us that most of the infections were coming from adolescent girls and young women, who accounted for 22% of all the infections that we registered in the year 2022. We also tried to look at STIs and how we were doing. So this is considering that condoms prevent both HIV, STIs, as well as unintended pregnancies. Talking of STIs, the year 2022, we registered a staggering 440,000 STI cases. We also started seeing a rise in registrations of new hepatitis B infections. And as we are speaking now, we are standing at a prevalence rate of between 5.1 to 7.9%. Malawi is one of the countries with the highest birth rates, but unfortunately, most of our pregnancies are unintended. We don't have current data present, but data from the previous years shows that almost half of the pregnancies that we register in Malawi are not intended. So between 2015 and 2019, we were registering an average of 866,000 pregnancies per year, out of which over 490 were estimated to be unintended. And unfortunately, we also had a lot of pregnancies ending in abortion because obviously they were not wanted. Next slide, please. So with the situation being as bad as we have seen in the previous slide, we had to sit down and think of what we are going to do when it comes to trying to address the challenges that we're facing in HIV as well as SRHR. So one of the things that we did was to look at the programs that we have in country and see where we need to put attention so that we close the gap. So the reason now we thought of addressing or integrating condom distribution and promotion were because, one, we've seen the high rates of both new HIV infections, STIs, as well as unintended pregnancies. But prior to also starting this, we had run a cost effectiveness modeling through the goals modeling, which showed us that condoms are the third most cost-effective interventions where HIV prevention is concerned. So we had ART coming first and then PMTCT second, and condoms was the first program, non-ART program, that was coming in highly cost-effective. And beyond being cost-effective, we know that condoms are easily accessible and they are the only HIV prevention intervention that can be accessed out of a health facility. So the goals modeling showed us that condoms had averted and approximated, on average, 117,000 new infections between 2010 and 2020, which is quite a huge number. So for us, it was evidence and confirmation that we really need to do something about our condom programming. Unfortunately, we were registering suboptimal condom distribution, which was always below our national targets. And unfortunately, also it was localized to public health facilities. So out of all the condoms we were distributing in the country, 67% were distributed through health facilities and only 7% in the community, where actually many of our target populations reside. We also reported low condom usage through our several studies. So the Malawi Population HIV Impact Assessment, the MFIA, reviewed that the correct and consistent condom usage among adults 15 to 49 was sitting at barely half of the target population. So this is low. Our target is for 80% of the target population to use condoms, and 50% means that we were 30% short of our target. We tried to also look into the target population specifically, and only 64% of young people 15 to 24 were using condoms. And unfortunately, these are the populations that are bringing in the infections. Only around 48% were using of female sex workers reported consistently and correctly using condoms, and 70% among MSM was reported the highest use of condoms. Our comprehensive condom program follows the total market approach, where we are distributing and promoting condoms from 3 sectors: public, socially marketed, as well as the commercial. But unfortunately, an assessment done early in 2023 with support from the Condom Strategic Initiative reviewed that implementation of the TMA was very suboptimal. Next slide. All right, so as I said, we did an assessment early in 2023. The weak implementation of the TMA was one of the issues that came up, but also it reviewed weak condom promotion and demand creation across the country. So following all these facts that I have raised before, the NCC in their meeting had to strategize on how we should move forward to make sure that, one, we are improving access through the distribution, but also that we are promoting the consistent and correct use of condoms. So a call was made to all stakeholders and implementing partners to start now integrating condoms and condom distribution and promotion. The integration goes beyond just within condoms, but also the call is made to make sure that we are integrating condom distribution and promotion in other health services, so that everywhere a person goes at the health facility, they find condoms, they can access condoms, but also condom education, even in our communities. So the solution that was made was that all condom distribution initiatives should be complemented by condom promotion. So that is basically saying no condoms should be distributed without being promoted or education offered. And no condoms should be promoted without the supply of condoms being available. Next slide. All right, so our main aim for integrating the distribution and the promotion was basically to improve access. We wanted that every person who wanted a condom should find the right condom at the right time, at the right where they need them. So it's basically you should find the right type of the condom you need, total market approach, when you need them, the timing, but also where you need them, the place. So this is where we are also going beyond the facility. But also in addition to that, we want to promote correct and consistent use of condoms and lubricants. So the low condom usage that I had shown previously does not really relate to the number of condoms that we distributed, but it means that quite a number of people who accessed condoms did not use them correctly. So as a result, that was not counted as a condom usage. So in this initiative, we are trying to make sure that people are correctly and consistently using condoms. Next slide. So in our programming, we are very targeted. We are targeting at the populations which are registering high rates of HIV infections and intended pregnancies, but as well as STIs. So I think this should be common across the region. We are talking of age-wide abuse, FS abuse, men having sex with men, and the like. So usually our programming in Malawi is focused on geographical areas with high disease burden for both HIV and STIs, and mostly for these, this is the southeastern region of Malawi. Next slide. So basically that is a snapshot of the situation where HIV, SRI, Chala, as well as HIV and SRI, Chala is concerned in Malawi. I'll hand over to Matthews. Thank you.
So thanks very much, Betha, for taking us through the background of what we are doing as a condom distribution in Malawi. I hope you can hear me, all of you.
Yes, we can hear you.
Yeah, I'm using somebody's gadget, so yeah, so I'll take you through how distribution is done in our country to the last mile. So next slide, please. Yeah, so in Malawi, what we are doing is that the condoms are distributed through the health facilities, and also we are doing the last mile distribution, and this is now done in the hotspots that are being mapped. The hotspots include, for example, the salons, as well as the barber shops and also the bars. So we also use the riders to take the condoms to the last mile. These riders, they take the condoms from the health facilities to take them to the communities. And also the health workers plus the volunteers, like the health surveillance assistants. Now we are calling them the disease control assistants, and also the community-based distribution assistants. They help us in the distribution of the condoms at community level. And we go further and also use the peer educators to distribute condoms in the communities, just to make sure that everyone is getting the condoms. So we have also gone further that we are also using the non-human condom dispensers, especially in the higher learning institutions. We have mounted some condom dispensers just to make sure that the condoms the students are accessing the condoms. And on this one, it's only the public institutions. Those that are the higher learnings that are managed by CHAM, especially the Catholic ones, they are not accepting these condom dispensers. So we have done this, we have taken them to other districts that are closer to make sure that people are getting the condoms. So from the pictures, you can see the picture that is to your left is just depicting a rider delivering the condoms in the community. That's one of the fishing districts in Mangochi, where we are using the riders. And the down picture is also showing girls with their fellow peer educator. They're discussing a number of things, but one of them is now the condom distribution. They normally take the condoms when they have their own community meetings. So we are using such kind of platforms to distribute the condoms. Next slide, please. Yeah, so we, apart from now distributing the condoms through the health facilities, we also have the last mile distribution initiative. And this last mile initiative distribution is to make sure that people should get the condom. They should have the condom when they need it. So we have targeted, we have made it sure that we should we should reach out the condoms to the remotest areas and the hotspots. So we have mapped the hotspots. These hotspots, they include the fishing hubs, the bars, and any other place whereby we feel like it is a hotspot. So this process of mapping the hotspots is continuous. And in parallel to what we are doing, distributing through the health facilities, we are also using our partners, those that are doing socially marketed, distributing the socially marketed condoms, they also have a project we call it Empower. They're also distributing the free condoms. So these are the parallel distribution apart from using the health facilities to reach out to the people, to the community where people get the condoms. Next slide, please. Maybe before you go to the next slide, I just wanted to say something about the picture that you saw. Maybe you can go back to that picture. You find that the last mile distribution, when we're talking about last mile distribution, is to save even the hardest, the hard to reach areas. So that picture is showing people are on the rake. They're taking the condoms to one of the hotspots that was identified in one of the districts. So they had to cross the lakes just to make sure that the condoms are delivered there. So we are using every possible means to make sure that the condoms are reaching the people that are in need of them. Next slide, please. Yeah, so this the dramatic focus is just focusing on how the distribution is done in Malawi, especially we are looking at the free condoms, the public distributed condoms, how we are doing it in Malawi. So I will take you through how the picture, what it means. You can see that the distribution starts from the warehouse. This is after now determining the quantities of the quantities where each district will need or the place will need. So you realize that we have the thick lines that are black, and also we have the dotted ones. The thick ones is what we used to distribute in the past, whereby all the condoms were from the warehouse, they were going to the health facilities. Then the people were getting the condoms from the health facilities. But after the last mile distribution, we thought we need to go beyond the health facilities. So now we are distributing condoms from the warehouse, probably direct to the hotspot. It can be to the bars and wherever it is identified that the condoms can be accessed by the communities. So we are distributing through the health facilities, but also they are identified hotspots, for example, the bars, as I've said, and we are also have designated warehouses apart from the health facilities where people can access the condoms and distribute to the communities. And at the same time, we have now what we call the ad hoc delivery of the condoms. We don't want people to just run out of the condoms, but they should have at least a backup system. So even if you from the hotspots and the other final destinations, they run out of the condoms, they can go to the health facility and get the condoms and get the condoms from the health facilities, despite that maybe they got the consign the first supplies from the national level. So this is just to make sure that the condoms are reaching out to the people that want them. So all these are served by the public sector to make sure that all the identify all the people that are in need of the condoms are getting the condoms at the right time. We don't want actually to get in the situation whereby maybe we have frequent stockouts. So people can get the condoms from the health facilities, and we have gone beyond to the mapped hotspots where the warehouse guys can drop the condoms, just to make sure that we are not running out of the condoms in the designated places. Next slide, please. Yeah, so I think I would end from the where we are distributing, because this slide, I should give it to Philip to express, to share with us how the socially marketed condoms are distributed in Malawi. So over to you, Philip. Thank you.
Philip, are you there?
Sorry, I think we can't hear you.
Philip, are you around?
Now we can hear
Yes,
you.
can you
Just
take
go
it?
ahead.
Can you take it up?
Or maybe Philip is out, so I'll
Yeah.
attempt to explain how distribution of socially marketed condoms is done. We have two social marketing partners, FHS, where Philip works, and we have BLM, an affiliate of Mali Stops. So their distribution is quite similar. So this one will work. And we have, we socially market both the male and the female condom. So the figure on the left is how the male condoms are distributed. We have the condoms imported to the central level. And from the central level, we have several distribution points. So the condoms would come from the central level. We have sales representatives that work in the different regions. So we'd have a sales representative for the northern region, a sales representative for the central region, and a sales representative for the eastern as well as the southern regions, respectively. So the sales representative distribute condoms to different outlets, which include wholesalers. So you find the condoms in retailer shops such as the ShopRite and the like. We also have distributors where the sales representative also deposit the condoms for further distribution. Chain stores have mentioned about that. We are also distributing the condoms to bedding centers because there's a growing tendency in Malawi where our young people, instead of doing other things, they spend most of the day in the bedding centers. So we've had to strategize to make sure that there are condoms there. Once they win, they go out, at least they go out with a condom. We also have liquor shops distributing the socially marketed condoms and other non-traditional outlets. So the non-traditional outlets would be places which are not included in this, but as time and situation demands, the condoms would have to go there. On the other side, for female condoms, the care brand, this one mainly because it's the thing with a female condoms is kind of different from the male condoms. So we had to start to sit down and strategize how we are going to promote distribution of the socially marketed female condom. So normally for this one, we use door-to-door sales where a distributor who also acts as a peer educator will take the condoms, let's say to a female sex worker, and then they give education first before leaving the condom. The reason we are doing this is because we realized that the uptake, we could distribute the female condoms, yes, but the uptake was quite low. And considering that this is socially marketed, we would want to get something out of the condom, it was very important to make sure that where we leave the condom, yes, we get the money, but we also ensure that the condoms are used. So for this one, this would also be done in non-traditional outlets, places where I wouldn't normally distribute condoms, but as the situation demands, the peer educators would go there. So we are using peer educators, as I said, we call them queen mothers here. These are basically female sex workers who have authority in the hotspots, taking the female condom to their fellow female sex workers. But before they leave, the most important part is that when they take the condoms there, they make sure to give education on how the female condom should be used so as to ensure that the condom is actually used. Next slide.
Yes, Philip is
Thank
back.
you.
Maybe
Okay,
Philip is
Philip,
back. Maybe before Francis comes in, you can
Oh,
all right,
comment.
great.
Sorry.
Perhaps you can
sorry.
speak.
Yeah, thanks. Sorry, I got booted out, but I think Beth has covered it very well. We should be able to proceed. Thanks.
Welcome. So Francis, you can take it from
Thank you
here.
so much. Yeah. Thank you so much, Chair. And thanks so much my two colleagues who have presented before me. So I'll take you through I'll co-present the condom promotion part together with Philip. Next slide. So before maybe I start with that slide, I think we just wanted to remind you that all health products, their availability doesn't really translate to uptake or use. So use and uptake very much dependent on how best the product is promoted. So for the country, Malawi, we have just finalized the condom and lubricant communication plan. That is serving as our guiding framework for the promotion of condoms and lubricants. So this plan has got the key messages which are very contained in this plan, and these key messages do have an action reason to believe and also call to action. So these messages will be adapted by various implementers as they will be conducting various promotion and the education services regarding to the condoms and lubricants. So the condoms are promoted at all points of distribution, as already mentioned. And our promotion drive follow the socio-ecological model and the human-centered design, whereby we are talking about looking at factors that influence behavior, a person's behavior at all levels, being at the environment, be it at the interpersonal and also the self-efficacy. And we also look at what the users of the commodity demands and needs for the condom to be used and accessed properly. So the pictures which you are seeing, the posters, to your left, we are seeing a peer educator demonstrating the collect and use of the male condom, and the picture in the middle is just demonstrating that even a signage or a symbol say this is a distribution point where you can access condoms in, and this is just one of the hardest to reach areas. I think this is a tea plantation site, and the other poster you are saying that it's in the hotspots like a bar. Next, please. So our condom promotion employs a multifaceted approach. We are heavily relying on the interpersonal approach or condom communication. Looking at when we wanted to communicate about the sensitive and also very pertinent issues that triggers a person's behavior. And we haven't actually left out the traditional mass media, and looking at also on the current trend, the global trend, we have also adapted to the visual platform. And the advocacy initiatives are used to support the condom programming because there are some other factors which hinders the access and the promotion of condoms because of other factors like culture and the like. So we advocate for opinion leaders and the traditional leaders and also other people who hold influence to make sure that a condom is given the necessary support or resources to reach the intended user. Next. Yeah, so I think we just wanted to demonstrate. I know there will be a good slide where we will demonstrate quite well on how best how these initiatives, the promotion initiatives, have actually impacted or have reached. But looking at the peer-led interpersonal demand creation for adolescent girls and young women, just a snapshot, and their sexual partners, we are looking at the reach of close to 300,000 plus. Those are cumulative figures that we reached over the period that is being reported here, and also integrated market days using the cultural and cultural festivals. We have cultural events that conducted here in country, and we have also social events. So we reached out to over 500,000 people advocating and creating awareness on the correct and consistent use of condoms and lubricants. So that is not a mean figure in terms of prevention of new HIV infections and STIs and also unintended pregnancies. We also used other supporting platforms for condom promotion and distributions, like maybe the cinemas and the like. Next, please. So after almost 10 years of absence of a condom campaign, the country through the SAI supported us to have a mini campaign, and this mini campaign we co-designed it and implemented it, and we had to give it as an identity so that people could remember. It could have an emotional trigger in terms of a name. So we called it the ICHNSA campaign, and the ICHNSA campaign was piloted in 3 high burden districts to complement the distribution of the last mile efforts, as already said. So the initial interventions activities involved the use of radio, community radios, where we identified 2 radio stations. One radio station was able to cover 2 districts, and the other, I think it was able to cover the other 3rd district. And we used the promotional jingles and the radio spots, and we also had the live radio mechanism programs, dialogue sessions, and we also designed posters and other print materials to promote the condoms. Next, please. Yeah, so I just wanted you to appreciate that some of the promotion materials, education materials that we designed and that we advertised through the virtual platforms include the social media posters, and we were using the Facebook, the Twitter, and also the organized WhatsApp groups where we could identify the priority audiences which were mentioned, and we could penetrate through that. So every week we would actually disseminate 1 or 2 and relate a discussion on those, and that also triggered some appetite to use and know more about the message that was contained and the other follow-up questions that needed to cement the person's behavior to adopt a condom use lifestyle. Next, please. Next slide. Yeah, so the ICHNSA campaign managed to, as I said, piloted to include 3 districts. So with the radio spots and jingles through the community radios, we reached slightly about a million plus people, and with the that is about it now, the community radios, the 2 community radios. Now we had to extend the promotion to national radio station, where we reached about 6 to 7 million listeners per day, and through the same radio promos or spots, and through the interactive radio magazines, we reached about close to 700,000 people, both in Mulanje and Cholo, and the number of adolescent girls and young women and the adolescent boys and young men reached through direct sessions. In Mulanje, we had the 56. These are groups, not individuals. And in Cholo, this is another district, about 36. And a number of female sex workers that we reached through the direct sessions. In Mulanje, there are 26 groups, and in Cholo, there were 13 groups. Next, please.
All right, so it seems Philip is having internet challenges. So I'll just take this part until he joins or rejoins. So alongside the Ichenetse campaign, we had other activities being implemented by other implementing partners as well. This one is Empower. Empower is implemented with support from USAID and covers a number of HIV prevention programs, including the comprehensive condom programming. So Empower has now transitioned. We are now calling it Kuteteza. This project supports social marketing of condoms and also supports logistics for condom procurement as well as distribution of condoms to key populations. The social marketing under Empower supports the marketing of Chishango, which is a male condom, and Care, which is a female condom. But when it comes to the other activities, Empower supports both the public and socially marketed condoms. So they have activities that support stewardship at the subnational level, but also demand creation. But for this component, specifically, I will dwell on the demand creation activities that Empower supports. So how this is done is that there is a combination of entertainment and education that is done to reach out to young people who are vulnerable to both to HIV pregnancy as well as STIs. So entertainment shall mean that there are several activities, including shows, social media, and the other platforms. For most importantly, because the target population are young people, Empower, the condom promotion lies largely on the trending events to craft messages, but also to disseminate the messages. Next slide, please. Yeah, so the delivery approach, I think I already started to touch on that. We use several approaches with the Empower to reach out to the target population. Mass media promotions, we still do that, but we are also relying mostly on interpersonal communication, like I explained earlier about the female condom. We are also heavy on our digital outreach. So there's actually a Facebook page and also promoting ads through different pages on Facebook, Twitter, Instagram, just to promote condom use. Basically, the purpose is to improve condom use, but also to improve access. Next slide. Yes, so we've had some awareness campaigns under Empower, which mainly aimed to reach out to young people promoting condoms. The goal was to sensitize our young people on the importance of consistent condom use, but also to promote all the three sector condoms free, the public, the socially marketed, as well as the commercial condoms. So Empower covers all districts. They have impact districts, but for certain activities, but for most of the promotion activities, the target area is all districts. That is 28 districts from north to south. So usually there are 4 shows planned per district, and the target and the reach has been over 10,000 people per show. So by a show, it doesn't mean sitting at one place. They will be moving from one trading center to another, and to another. So that will be counted as one show. And then they will come again for another show. So they will be like lot shows in a way. The next slide. Other than the awareness campaigns, Empower also is specialized on interpersonal communication, but also reaching people personally, especially for the hard to reach populations. So here, the interpersonal communication is heavy on the female condom, explaining how the female condom works, but also making sure that we are bringing the condoms closer to the consumer. And we are also talking of empowerment. The situation in Malawi is that mostly it's the man who decides whether they will use a condom or not. So Empower, as the name entails, is working on empowering women to be able to initiate the decision or negotiate for the decision to use condoms, especially female condoms, so as to transform their sexual health. we also under Empower want to increase female condom usage among sex workers. In Malawi, sex workers have the highest prevalence, almost 50% of our female sex workers are living with HIV. But unfortunately, the usage, as we may have seen, is also just around 50% among the sex workers. So we thought it is important that we really work with sex workers to make sure that all of them, they are using condoms, they are able to negotiate with their clients on condom usage. So other than the interpersonal communication, we are also using the mass media, disseminating messages through the radio. Zodiac and MBC radios are the two most listened to radios, and with over 5 million listenership at the time of the dissemination of the messages. And through this initiative, we reached to over 600,000 people, and this is through interpersonal rather, we reached to over 600 people in a month. Next slide. All right, so we are also disseminating messages through the social media. Condom messages are now flooded on social media, we can proudly say that. And through the social media, we have managed to reach to 2.5 million people and left 27 million impressions. Out of all the people that we have reached, we have managed to engage with 17.7 million people. The FHS page, which is sponsored by Empower, has over 13,000 followers, and around 500,000 content interaction has been recorded. So those who we say engaged, these are the people who commented, asked questions, or either came to our inbox to ask some questions about condoms and lubricants, HIV prevention, SRI, HALA, because of the messages that we disseminated through the social media platforms. Next slide. Yeah, so apart from Empower, we have other partners as well. BLM, an affiliate of Mali Stops, also goes big on distributing socially marketed condoms, but also promoting condoms in general. We are also working with several civil society organizations. We have KP-led organizations distributing, but also promoting condoms. As you can see down left, that's a billboard on Paul Kagame Highway in Lilongwe promoting Manyuji. Manyuji is a socially marketed condom. And on the other one, it's just an awareness campaign going on where people are promoting condom use, demonstrating how condoms should be used and the like. Next slide. All right, aside from the condom promotion activities, we went beyond condom promotion to advocacy. So the advocacy, we implemented the advocacy activities after noticing some low interest in condom programming at all levels. So from down bottom, the general public, people could not really demonstrate interest to talk about condom issues, but also up there. So this is a multi-sectoral program, but you'd see that the interest perhaps was just coming mainly from the public sector. So we needed people to come in so that we are all doing this together. So some of the advocacy initiatives are the distribution and promotion of condoms during social and casual events. I'll not dwell much on that because Francis talked about that. So the International Condom Day, which we all know, but most importantly, we had the Civil Society Advocacy Forum for HIV and related conditions joining us to advocate for improved access, increased participation, but also advocating for increased public interest in condoms and lubricants. So the CSAF, together with NAC and the Ministry of Health, we did a couple of activities, of course, supported by the Condom Strategic Initiative as well, we should acknowledge, where we engaged different media platforms as well as different institutions in condom programming. So we'll talk about the growing interest in the media, but on the right there, that was just one newspaper reporting on the call from the Civil Society Advocacy Forum for improved condom distribution, but also condom promotion. After this, we had several programs airing on both radio and TV, but also several programs printed in our newspapers advocating for improved participation. So for improved participation, we are looking at improved private sector participation in the program. We have issues of religious barriers in Malawi. We wanted to call on the religious sector as well to, instead of being a hindrance to us, support condom distribution and promotion. Next slide. All right, so I'll take you through, after we have done all these, what has been the impact? Where are we looking at where we are coming from? Next slide, please. All right, so qualitatively, we are noticing an increased condom noticing an increased condom and lubricant distribution. I will demonstrate that as we go forward. But qualitatively, we are also noticing an increased public as well as media interest in condoms and lubricants. So I have personally received several calls from the media trying to get information on condoms or requesting for stories on condoms and lubricants. We've had Francis reported on airing of condoms on Zodiac. So with the Zodiac, we paid for the ads to be aired for 2 months. And then because of the engagements that we had done through the advocacy, Zodiac offered as part of their corporate social responsibility to offer to air the jingles for another 2 months. So the kind of interest, and beyond Zodiac, we had even also call us in to conduct live radio programs on condoms, engage with the young people and the like. So that kind of interest that is now here was never here before we started the integration of distribution and promotion. Apart from that, so every HIV program really needs participation, really needs strong stewardship structures. Initially, we could struggle to just set up a meeting for the National Condom Coordinating Committee, or if we did, the room would be half full. To avoid being negative, I'll say half full instead of half empty. But now, when we call meetings for the Condom Coordinating Committee, for example, we are sure that people will participate, we would have the quorum reached. And this is also being demonstrated down to subnational levels. Next slide. Next slide, please. All right, so going quantitatively, I'll start with the 3 districts where we implemented the Chenete campaign. This is achievement against the set distribution targets. So starting with Cholo, when we started with the distribution as well as the promotion of condom activities, we could only distribute 25% of the set targets for the districts. But after starting this, as we were ending 2022, we had surpassed the targeted 80% to surpass even 100% of the targets that we had set. For Mulanje, we ended at 66% as at the end of December 2023, and Mangoji 38%. So we also went back to look at the issues at what was happening in the 2 districts that did not manage to reach up to the set targets, and that I'll explain in the next slide. And the next slide, rather. Next slide, please. Yeah, so in terms of national distribution of condoms, as I'll start with the pre-COVID era in 2019, our targets between 2019 and 2022 were uniform 155 million. We had to revise that though using the condom needs estimation tool. So for 2019, we distributed around 110 million, which gave us a 70% achievement of the target. Then we went into the COVID-19 era where, as we all know, health services were interrupted, and so was condom distribution. And so we dipped to just around 80 million and 88 million in 2021 and 2020 and 2021 respectively. In 2022, we went back to our normal, which was just around 100 million. So we distributed 107 million male condoms in 2022. And this is when we had strategized now to go into strengthened programming. So as you can see, when we started with the distribution and condom promotion to the last mile in 2023, where our target was around 147 million male condoms, we managed to distribute around 140 million. And this is an achievement of 94% against the state target. And this is the first time as Malawi that we reached over 90% achievement of the target. So because it was our first year in implementing this initiative, we could forgive the 6%, but we thought that we've done well in terms of condom distribution. In 2024, by April, from all the sectors, we have distributed around 80 million. Our target for this year is 163 million. So 80 million means that we have so far achieved 49%. And this is for the first third of the year. We have 2/3, and we are very confident that for this year, we may reach, even beat our target. Next slide. All right, so because it was a first for us to do this, kind of a first. We've done the condomized campaign a decade ago, but over a decade we didn't do a lot of condom promotion. But because it was a first, there are lessons that we learned that we think that we would love to share with you in case we may improve programming in our respective countries. Next slide, please. All right, so the very first lesson that we learned is that strong multi-sectoral, but also multi-level coordination and stewardship are key in making sure that we are implementing optimized condom programs. So to be honest, if we really didn't have strong coordination structures, especially at the national level, we could not have reached this far. But now, because we had strengthened our stewardship, our coordination structures at the national level, we also tried to make sure that all partners are reporting to the best of our ability, but also that we are able to monitor what is happening. So in every NCC meeting, all the key players report, and then they get questions and they get action points. So they go out knowing that when they come back next, they will have to report. And as you can see, the room for people to relax on what has been given to them is quite small. So this showed us that we really need kind of strong coordination at all levels, not just at the national level, because we had districts where coordination was not good and the results were not satisfactory. In addition to having strong coordination and stewardship structures, we also learned that in developing messages for condom promotion, we really need to involve relevant stakeholders, including the target populations. So it's not a thing that you can sit in the office and think we are going to craft this message for a transgender woman, and then you put it out there. They may not accept it. It may not be appealing to them. So what we've been doing is, let's say we are crafting messages for transgender women, we make sure we involve them in the message development. We involve the partners that are implementing for them, so that by the end of the day, we have messages that are acceptable but also appealing to them. When it comes to condom distribution, we learned that improved quantification mechanisms would improve availability of condoms for us. Normally, we would have the commodities in the central warehouse, but then because the quantification was maybe not done well, especially where implementing partners are coming in at the district level, we could report here and there issues of stock outs. But when we worked together to improve quantification mechanisms, we had our CNET customized. We saw that the issues of stock outs were becoming lesser and lesser as the time went. The other lesson that we learned is that our audience in Malawi is quite fragmented. We have people that are casual, we have people that are religious, we have people that are elite, they want to listen to the radio, they want to read the newspaper. We have people that are hard to reach. You can't reach them with any kind of channel except interpersonal. So with this lesson, we learned that if we really want to reach everyone, if we really want not to leave anyone behind, we really have to craft messages and use smart channels where everyone can be reached. One lesson that we learned from the HNSA campaign is that the generation of young people born after the year 2000 are not really afraid of HIV and STIs. To them, you can get drugs for those. You can get treated for an STI, you can get ARVs besides HIV won't come out today, but they are afraid of pregnancy because with pregnancy, your parents will be mad. Everyone will know that you were sleeping with other people and the like. So if you tell them condoms prevent HIV, they'll be like, yeah, so what? But we've learned that if we really want to influence condom usage among them, we should combine the messaging. Condom prevents pregnancy, condoms prevents HIV, and the like. Next slide. All right, we also learned that strong community involvement optimizes condom promotion. We learned a very good lesson in Cholo, where the district council as well as the communities were very participative in the condom to the last mile distribution as well as promotion. And as a result, the targets were even beaten. But also that participative SPCC, so most of the times it's very easy for us to develop messages and send them out there. But for the sessions where we gave people a chance to participate, ask questions, say their comments, we could see that the impact was better than just developing the messages and sending them out. We had a few instances where messages had gone out but incorrectly. Fortunately for us, we have a legal framework that gives for all HIV messages to be vetted and accredited by the National AIDS Commission. And what we learned is that as we started enforcing this with the condom program, the messages that are out there are correct, but also acceptable and appealing to the target audience. One thing that also came in handy in our learning is that we really don't need money for everything. So I think you should have seen in one of the presentations where a box was hung at a hotspot. Normally, you would think we need a poster printed that would need money or procurement processes. But for us, we didn't have the luxury of all the resources at our disposal. So we had to sit down and strategize. And we thought, okay, we could use a condom box, an empty condom box, and hang it. In that way, people will know that there are condoms here. So what we did was devise that mechanism and educate the communities about like when you see a condom box, it means you can access condoms there. Or in most cases, we also just could print condoms are available here or use condoms on a simple A4 paper and stick it on the walls, on the trees. So it really didn't cost us a lot to do that. So we learned that it's possible to do it the low cost way. One thing that also came to our learning is that female condoms promotion will not work with the general kind of condom promotion. Most of the promotion that we've been doing is general, except for the Empower one. So with the Empower, that's where we are distributing a lot of female condoms because it's interpersonal. So you've learned that with female condoms, it will require focused and tailored promotion for us to be able to push the volumes that we are distributing. Next slide, please. Great. We would love to say that we've had some opportunities along the way, supporting us, enabling us to implement these initiatives. I should say that we've had partners and support from both funding and development partners who give a standing ovation to the Global Fund Strategic Initiative, USAID, Malawi government. So this enabled us to have consistent and sufficient supply of commodities in the country. So at national level, we've always had consistent and sufficient supply of both condoms and lubricants. Our other opportunity is the strength of our coordination structures, but also moving forward, we are hoping that we'll close some gaps as we've just rolled out an upgraded system where we want to monitor stock levels at the community level to deal with the issues of stock outs at the last mile. We've encountered some challenges. I'll just mention a few because we have had more positives than the challenges, but otherwise, a low internet coverage affected our reach with the virtual media messages. So we developed some really beautiful messages that we thought we could reach the young people everywhere. But because most of our population is in the rurals, we could not be able to reach them. We could only rely on the radio where the visuals could not be useful. Limited resources, we are in Africa anyway, and I think that the issue of limited resources is not just unique to Malawi, but the important thing is that we find a way of trying to work with the resources that we have. Next slide, please. Great, so all this that we have presented, it makes condom sense, right? After all, condoms are cheap, easily accessible, avert so many costs that can come if one hasn't used the condom. Next slide, please. Reaching this far, thank you for your attention.
Thank you, Betha, for the elaborate presentation on lessons learned, impact. To our colleagues from Botswana, South Africa, and Zimbabwe, and I've seen people from Kenya as well. Time for questions and answers. I've seen some questions in the chat box that have been responded to, but raise your hand if you have a question. Our presentations have covered condom distribution, promotion, and lessons learned. So on distribution, we are saying we are using different means to warehouses, from the health center to the end user. We use peer educators, we use promoters for both public condoms as well as condoms. And for the promotion, first presented on interpersonal as well as virtual platform. So we open the floor for your questions, answers, or take home messages from the discussions and presentations that we have had. Thank you.
So thank you so much, Malawi team, for the very, very excellent and very, very great presentation. I know we have a few questions. It would be great maybe if we could get maybe some of them addressed, time allowing. The first question was from Kumbi Chatora from Zimbabwe, PSH, and she's asking whether your distribution of the free condoms where social marketed condoms are sold, how that affects the social marketed condoms. Isn't that crowding that out? The other question was from Dominic. I think this is from South Sudan. They're interested, they're really interested for the data because they always do condom distributions, but very hard to measure or evaluate any experiences on. So he's asking for any experiences on data and condom use. There's Humphrey Ndondo who wants to know to what extent is the use of shows and other mass media interventions effective in reaching hard-to-reach communities, such as sex workers and MSMs. And I think in your delivery model from the warehouse to health facilities and also direct from health facilities to the distribution site, how do you avoid duplication of delivery to the same delivery points? So maybe if we can get responses to some of those questions.
Great, thank you, Lucy. I'll start taking the questions, and we are a team here, so my colleagues will come in as well. In terms of public condoms overcrowding the socially marketed condoms, so we segment our target populations who we want to target to. And normally with the last mile distribution, what we've been doing is at a hotspot, we have public condoms and socially marketed condoms because we want to cater for different preferences in the population. We've been doing this without a challenge really in 2022, but I should concede that earlier, somewhere around January this year, we had received a report from one of our social marketing partners about low sales in one of the districts. So when we probed a bit further about the situation, we found that the condoms were kind of distributed to areas where public condoms should not be distributed because they are marked for not really distributed, but should not be the focus. So socially marketed condoms should be a focus rather. So where we are going to address this issue is we are planning to go into a targeting kind of sensitizations to all our distributors and implementing partners to make sure that we are only distributing the right type of condom to the focused areas. The other types may be available, but we give focus. So let's say there's a show somewhere, musicians are coming in because we know that there are people are coming to pay. We know for sure they may be able to spare a little purchase to buy a socially marketed condom or a commercial condom. We would rather focus the socially marketed condom or commercial condoms there than the public condoms. So this is what we are doing to make sure that we are closing any small taps that may be there, the chances that the public condom may have overcrowded or may overcrowd the socially marketed condom. I'll answer that one like that. In terms of data, I'll leave it to Matthews, Martin, and Stella on the call to also respond on how the data is collected. But from the social marketing sector, we have the data is reported directly to the national response. So quarterly, it is practice that the social marketing partners report to the National AIDS Commission as we are compiling the national response reports. So we receive reports from the public sector, from the social marketing sector, and estimates from the commercial sector to feed into the national response report. So it's practice, and because of the strong stewardship mechanisms that we have put in place, it is not a challenge because anyway, they will have to report to the NCC, and they know that we also have to report to the national response. Matthews, you can take the question on data, how data is.
Yeah, thanks very much, Beth. I think on that one, I would ask Stella maybe to address that question because she has joined us, so she can shed more light on how we gather our data in terms of what we have reported so far.
So I hope you can hear me.
Yes, we can.
We collect data from facilities. Every quarter, we have a TB HIV quarterly supervision that reaches all facilities across the country. And we are able to get both the service and logistics data. So we'll have a team that will check on how much you have in the pharmacy, what the expiry dates of the commodities that you have, but also within the clinic, the service level, the service points where these services are provided, data is also collected. When we come back, that activity is a tools activity, and once the teams return We then utilize that data. It is entered. We have the Department of HIV management information system where the information is then entered and it is utilized to guide our ongoing distribution. We are at the start when we are enrolling a clinic, there will be a team that will assess the clinic and they will take coordinates of that particular service point. So those coordinates are used, the GIS coordinates, they are used by the distribution team to know where the facility is. We then, on a day-to-day basis, we have a toll-free service where sites are able to call in if they have any stock-related challenges. If you're running out of stock, you call in and say, I'm running low on this item. We will then guide you on where you can pick stock from. In using the management information system, because we now know where stock is and how much is there. In that system, even when we do the distribution within the system, so even the quantities that are provided in the distribution round are recorded. And when the distribution is done, we scan back the proofs of deliveries into the system. So we have evidence, physical evidence that the items were received, but also within the system, we know the stock that you have. So if you have any stock that you want to move, like we showed you some dotted lines where the stock can move from the facility to the community, we register that we distribute within the system. It is not possible for you to duplicate or to have any unwanted stock movements, because if you call, we will have you and we will lead you to where the stock is, and then you'll be able to utilize like partners within that region to support you with distribution from where the stock is to where we want the stock to go. And then we have the teams who go for the supervision or mentorship. They are able to actually look at the documentation at those facilities, because when you call, we give you a unique authorization code, which is recorded on your relocation, your redistribution book, as well as on the stock card. So when the teams go to your facility, they will see those unique authorization codes that match to what locations were done. And within the system centrally, we are able to note the movements of stock. So ideally, the most important that we should, I asked if you can hear me. So ideally, everything is managed centrally and it is a push system. Thank you.
Thank you. Thank you so much, Stella. I think we were struggling to hear you a bit, but I'm hoping that everybody has been able to get something. There's some questions also around distribution of condoms and lubricants. And there's a question here whether that is integrated in other HIV SRH programs, and also if lubricants are distributed the same way as the condoms.
Okay, great. So integration into other HIV prevention, HIV services is here, and this is actually where we started with the integration. So if you walk into an ART clinic here, you'll be able to find services. The KP programming, the HYW programming is also integrated with condom distribution. You may be pleased to learn that the condom to the last mile distribution project that we are implementing in the south, some of the districts in the south, is implemented in HYW districts, because we wanted to integrate the HYW project as well as the condom distribution project so that they go together. Beyond HIV services, we are also integrating the condoms in other SRHR services. You would find condoms in the family planning, obviously, because it's a family planning intervention, but in the STI clinic, because we know that if someone has come here, they are probably having unprotected sex. So you have condoms stationed there. Beyond that, we are working at making sure that the condoms are integrated in other service delivery points. So it shouldn't just be where SRHR HIV is talked about, because there we have already reached. We also have our HSS taking condoms to outreach clinics. So the outreach clinics, they are giving immunizations, they are giving family planning, they have condoms with them. But what we are looking at is, for example, an MCT clinic, we should have condoms there. So this is not just for condoms, but it's an agenda for the Malawi health sector in general, where we want to integrate services to make sure that we are making the most use of our resources. Yeah, so that's the thing. I don't know if there's another question, Lucy, or that's the one you asked.
There are a couple more questions. Kindly will bear with us, because I know it has been very interesting and very useful to everyone. There's a question here from Kabongombe regarding the Ichenetse campaign. You indicated output by people reached, and he's wondering, how do you describe reach? How do you describe reach in a campaign? The other question is around sustainability of the program, and especially the demand generation. There is a question here on how you are going to sustain these gains. How you're going to sustain these gains? Yes.
Thank you so much. For the reach, it's about people who have listened, who have been given the message, and who have actually been reached, or who have actually accessed the message through the radio listenership. I think that's how the reach is defined in terms of mass media or radio communication. Now, issue of sustainability has always been not easy in any other programming. However, looking at the way the Genesis and the results that have been produced, we have at national level, we are still engaging various partners to continue sustaining the activities that we have been implementing, of course, with a low cost. And as we continue lobbying for more funds to reach to a larger area. For your information, I think this was just like a pilot, because we did it in just 3 out of the 28 districts, and these are the overwhelming results. So scaling it up, I think it won't be difficult if we reach to potential partners, and if we demonstrate what this campaign has actually yielded within the limited resource basket. Thanks, and over.
Thank you. And I think in adding to the response, to respond to Rosemary about the sustainability question, I know where we are coming from, Aunt Rosemary, but I'll just say some of the things that we are doing. Most of the Ichenetse campaign was implemented with support from the Condom Strategic Initiative. When the strategic initiative came to an end in December, we went on with some of the activities. So corporate social responsibility came in, which demonstrates that there's an opportunity for private sector participation or contribution to the condom programming. So we are in the process of discussing how we should scale up engaging the private sector, because we know that our hope is there, especially because they have already demonstrated that there's a capacity for them to support us. And so we'll go there. But also the integration will also come in to sustain our programming. We have community healthcare workers, the disease control assistants. We have the community health nurses who go out to the communities for community outreaches. What we are planning to do in the spirit of the same integration is that when they go there, they also take with them the condoms, but also be able to give out condom promotion and the like. In addition, we'll also continue to go with the low-cost condom promotion that we already started. So we know that we'll need resources anyway, but we are also sitting down discussing how we should promote the use of the low-cost resources. Community participation came in handy also for us over the period. So beyond us going in the communities, having employed people going to the communities, we've been working with local organizations, CBOs, community-based organizations, who beyond the projects that we are implementing or have implemented are continuing with the condom distribution and the condom promotion. So those are some of the sustainability initiatives that we have put in place to sustain the gains. And so far they are proving to be effective because we are still being able to distribute condoms even before, even after the end of some of the projects. Yeah, suffice to say that we still have some projects running. Empower has transitioned to Kuteteza, which will be with us for the next 5 years. But other than that, because we are looking at the national picture, we are looking at sustaining that and scaling that up to the other districts. And this is what we are going to do. Thank you.
Thank you so much, Betha. Very interesting. I think the final questions are around the female condom, and the questions are around who you're targeting with the female condom, and also what has been the uptake of the female condom specific and any specific strategies for its promotion, and any lessons you may have learned from that.
Well, I was
Okay.
okay.
Yeah,
Great. You go ahead.
All right. For the female condom, I think like in other country, we're having a suboptimal implementation of the intervention. However, we have noted indeed that promotion of the female condom was seen previously only as to target female sex workers. So that mindset, I think we believe maybe it was also affected the numbers. However, we also noted that I think other promotional teaching aids, we didn't have the demo badges. Like we used to have the demo pens for demonstrating use of the same. So we are in the process of actually acquiring those demo vans to be used by PA cadres to educate their fellow peers. Aside that, we also wanted to do local bottleneck analysis to unearth issues that are actually affecting the low reach of the female condom. But it's not really a business as usual that we wanted to do with the male condom to replicate with the female condom. We wanted to have a special designed approach on how best to do the promotion of the female condom after discovering the bottlenecks that are affecting the update. You may add colleagues on the call.
Yeah, just to add, Francis, thanks for the response. Just to add that National AIDS Commission is planning to conduct a study on the female condom because we have noted the low uptake. So we are currently developing a protocol for that study. So once that is done, we'll also share the issues with our colleagues. And the study will help us to unearth those barriers and facilitate us to uptake. Thank you.
Okay, thank you so much. I think we just have one final question, whether the shops that receive the free condoms, whether they resell them or they distribute them for free. And also how you managed to conduct the delivery of condoms using riders.
Right, so the shops distribute the female condoms for free. Before leaving condoms at a hotspot, we have trainings with the hotspot owners on how they can, on storage, on distribution of the condoms for free. So for spaces where condoms can be sold, that's where we leave both the public and the socially marketed condoms so that they can be selling the socially marketed condom, which comes at a very low price. And then they distribute the public condom for free. So yes, the condoms that the hotspots distribute for free, and actually the distributors are not paid anything. They're doing this on a voluntary basis. And so far, we haven't had major challenges with them. It's the understanding, I guess, at the very start of the initiative that we are doing this because we are all stakeholders in as far as HIV, STI prevention is concerned.
Thank you. Thank you so much, Team Malawi, for a very great and insightful presentation. And thank you so much to the countries that have joined to learn from Malawi. We encourage that we continue to connect with each other so that we can continue to follow up on other things that we may want to learn from Malawi. So thank you so much, everyone, for your participation. We will be able to share the link. And I think here, just over and beyond the presentations, there's kudos to the Malawi team for the Ichenete campaign. There's also appreciation for all the work, that wonderful work that you have done as a country. So I think we will reach there for today, and hopefully we will be able to see what the other countries can be able to take up and learn. I see that South Africa have already indicated, so they will be able to use this how they'll be able to use their learnings from this presentation in terms of making sure demand and supply go hand in hand. So thank you so much. Back to you, Lekwete.
Thank you, Lucy, and thank you once again to the Malawi team. I will now be calling on our participating countries to share their key takeaways from today's presentation. So may we please have Botswana, a representative from Botswana, share key takeaways.
Okay, thank you. I want to thank Team Malawi and the organizers. Our take home for Botswana is the importance of coordination and stewardship, where it's coupled with accountability, where they indicated that they ensure that everybody, all the stakeholders who are participating in the condom programming, they're able to account at all the meetings on what is their progress. The other take home that I've also indicated is the strong community engagement coupled with peer-led implementation. Thank you.
Thank you, Makabo, for that key takeaway. On behalf of Botswana, may we please have a representative from South Africa?
Good afternoon, Ribwani Lifika from South Africa. So the takeaway for South Africa is for us to always couple the distribution together with the demonstration. Because actually, as they were presenting, I noticed that we got used to just distributing without actually getting to do the demo, because you actually find that someone doesn't know how to use a condom. And I think that's maybe something that we had taken for granted. Thank you.
Thank you, Livwani, for that key takeaway on behalf of South Africa. May we please have a representative from South Sudan share their key takeaways?
Yeah, thank you very much. This is Wilson Muga from South Sudan. One thing that we really picked up from this presentation is that the use of different approaches in last mile delivery. This is, I think, something that we can really adopt to ensure that the condoms, they reach to the last miles. Thank you.
Thank you, Wilson. Lastly, may we please have a representative from Zimbabwe share key takeaways?
Oh, okay, thank you, and good afternoon. What I heard from the presentation was that at the distribution points, there is some documentation that actually occurs as to the numbers of condoms distributed. That's good, because when what we have observed is that for commodities that are usually free, people don't really take that extra mile to document and maybe account for these resources. These condoms are free to the end user, but someone will have paid for these condoms. So I think this is good that we have also made an effort to make the outlets account for these condoms that are distributed. But maybe I didn't have a chance maybe to ask a question. You talked of riders delivering condoms, and looking at how bulky the condoms are, I'm just wondering how many condoms they can be able to deliver in one trip, considering that a box of public sector condoms, that big carton, contains 3,000 pieces. I'm just maybe looking at the packaging that we have in our country. Thank you.
Thank you very much, Anna. Perhaps we can get a response from the Malawi team on the question about riders distributing the condoms.
Maybe you can share the experience with the group of
Okay, so Matthews, if you are here, please take that question.
Okay, thanks very much, Beth. And Tim, I thought Edwin is here to explain more about the riders. But our experience with the riders, using the riders, is that actually we are using them in the last mile distribution, whereby they are taking the condoms to the very end user, whereby they are linking with the communities, and they are also dropping the condoms in the hotspots where it has been mapped. So this has proven to be effective, and they have also contacts of the distributors that are in the communities. They are linking to say if they're running short of the condoms, apart from getting them from the health facilities, they are using the riders to contact them. So anytime the volunteers or the people on the condoms that are used by this. So this riders are linked to the partners that are implementing the condom distribution in the districts. I think Beth highlighted that we have HYW districts where we are targeting the HYW in the 5 districts that are supported by the Global Fund. These are used in these particular districts, but from using the volunteers and the peer educators that we are using. So normally they use the motorcycles to go and drop the condoms, just to make sure that the volunteers or the peer educators, they are not walking longer distances to go and get the condoms. Because one of the things that we learned is that we normally have maybe stockouts because maybe the volunteers could not walk with the long distances. So we use the riders in these districts just to make sure that the uptake is enhanced. I believe if Edwin is here, he can add on the use of the riders. Thank you, and over.
So I guess one key thing with using the riders is that condoms saving an area are gotten from the facility in the catchment area. So the rider, whilst we acknowledge that the condoms are bulky, they can't take many of them, but the distance between the facility to the distribution points is not long, as if we could compare if they are getting, let's say, from the district level. But in this case, they are getting from the facility within saving that catchment area to go distribute the condoms. So they can be able to make a trip to an area, come back, get more condoms, and go to another area. So it's been working for us.
Okay, thank you.
Thank you very much to the Malawi team for that brilliant presentation, and thank you to our participating countries for your engagement. We will now be closing the session. However, if you have any questions, please do reach out to your country engagement leads, and the resources from today's presentation will be available on our SSLN website. Thank you, everyone. Enjoy your day.
Thank you.